तो बाकी -1% है अगर प्रैक्टिस करें तब बंद होगा अदरवाइज बन जाएगा वो भी 1% है और ये चांस नहीं जाती है बड़ा बड़ा बहुत ज़्यादा ऐसे जाती ही नहीं बैकअप बैकअप थोड़ा होगा लेकिन ये सारा यूनिवर्सिटी खुद की दी इलेक्ट्रिसिटी 1% है बड़ा बड़ा तब बंद होता है ठीक है
नहीं हम लोग सब डायरेक्ट यहाँ गए थे आप तो कौन निकाला है हाँ हाँ सर कल शाम को आना है क्योंकि हाँ हाँ
प्लीज एक बार जब अपने कोई रीजन से गिफ्ट है तो वो दीजिएगा पुट अ मैसेज पीजीआई के गिफ्ट होगा Finish? Just check with me. Did you get it? You told me Aadhaar and never sent the email. Super problem है. Definitely ये program start करें. आप लोग मैम actually 10 teams आ गए. 10 minutes में बोल रही हूँ announcement कि आ जाएगा. उसके बाद देखिए start करेंगे. मेरे पे just
कुछ पॉइंट्स होते हैं
So, how many teams have reached? Okay, let's start from here. Team one, one, two, three, no, four, five, four. So please, identify this accordingly. As you have given the registration, so it will be easier for us.
पढ़ लेते हैं टीम्स के साथ स्टूडेंट
फिर जैसे भी है कि एक बार टोटल टीम कितनी पहुंच गई? 4, 5, 6, 7, 8. बाकी people are coming or not? Strategy department से 10, 10, 10 teams are there. So please, every team, 3 members sit on a single line desk. Okay, so that we can differentiate the team. And the rest of people who are friends and everything, please they just move like that. है ना? आप लोगों की ये पीछे वालों की भी स्टार्ट करें। हाँ, आप ना इधर आइए।
टीम वाला काम करवाना
विजय सर।
नॉन प्लेइंग कैप्टन नॉन प्लेइंग कैप्टन
Team 1, 2, 3, 4. Participants, all participants, please provide your number. Please move to the front. Like, you know. 7. आगे जो खोलना है कार्ड घूमता फिर रहे कहाँ गया
लगा के लगा
आगे वाली बेंचेस ये तो प्लीज जिस थोड़ा में जो बाकी लोग हैं टीम जितनी आ गई है बाकी जो लोगों को पीछे बिठा टीम का डिस्टिंग्विश होना चाहिए 20 टीम को बिठा के हमें कैसे करना है ठीक है इवन बिट्टू को बाजू का नहीं बिठा के चला हां आ गया फर्स्ट ग्रुप
हम तो
10 टीम को आ गई
हम
है
रेडी
हाँ मुझे पता है यार आप लोग रेडी हैं टीम्स रेडी नहीं है
आपको जो जो शीट मिला है ना तो
अभी स्टार्टिंग में तो हम टीम का नंबर पर इसी हिसाब से करके हाँ एक टीम लीडर एंड उसके ऊपर एक मैं अभी टीम नंबर टीम 1 2 3 ठीक है टीम 1 2 3 ऐसे करके ना 4 5 6 ऐसे करके 20 नंबर तक का करिए सिंपल सी बात है अपने उसके ऊपर नंबर लिख देंगे चार ऐसे लाइन ना उधर तक बिठाने या तीन इधर तक उठा के रखें 3 3 6 तक खींचे जाएंगे 18 टीम को पहुंचेगी ये खाली में इस एक पेज इसमें मतलब ठीक है जस्ट उसको करिए अब नंबरिंग का करिए और 5-6 लोग से ये भी चेक भी करनी है हमें तो 6-7 लोग एक जगह बोल देगा बाकी सारे डिवाइड कर देंगे 6-7 लोगों भी ना एक्चुअली फर्स्ट हमारा वो है स्क्रीनिंग राउंड प्लस स्क्रीनिंग राउंड तो शीट्स फटाफट चेक करके फिर सेकंड राउंड स्टार्ट हो उसमें 16 लोग कौन से तो वो करेंगे
सब हो जाएगा तो बेटा जी टीम वाइज नाम दिया था आपने? नो, टीम वाइज नाम दिया था आपने? यहाँ पे टीम वाइज नाम नहीं था। कोई बात नहीं, तो यहाँ पे ढूंढ लो अपना नाम।
ये डॉक्टर जोसेफ ने मैसेज किया होगा मैंने
एक तो नाम है कि नहीं, तो पीछे लिख देंगे तुम्हारा।
मेरा नाम
पेज से लेवल नहीं जा सकते, अकाउंट से जाओ। Rnm Center की जो प्रोफाइल है जिससे पेज बनाते हैं उससे जा सकते हैं। पेज भी तो लाइव जाते हैं, नहीं
हमेशा छोटे दिखे।
पेज से लिया लाइव पोस्ट में हाँ जी मैंने किया तो था फेसबुक का किया प्लान नहीं था ना कोई। पेज सेलेक्ट कर लिया, उसके बाद गो लाइव का ऑप्शन क्लियर है, अकाउंट से तो आ रहा है।
किसी को कंफर्टेबल देने
हाँ
One, two, three, please be seated. All the participants, please be seated on your teams. We are starting. Any other team which is reaching a decision? कोई नहीं, आ जाइए तो स्टार्ट करते हैं। किसका कोई कनेक्ट ये वाला सीट यहाँ पे कौन है?
वैसे तो मुझे पता है वैसे
हाँ ठीक है, यहाँ से भी
ये सच घूम करके हेलो
हाँ हाँ
you have here study factor in the team members list. There is an answer. One sheet per team. For the three members, one sheet per team. Three sheets will not be entered, please. One sheet will be let's start करिए. नहीं अभी. इससे information कैसे
दिल्ली में फीस भी इतना सख्त नहीं है कई
हाँ जी
फैकल्टीज के लिए चेयर हमने खाली जो भी नहीं. हाँ ये उधर से ना बाहर से ये वही बना जा.
इसी की को डालें यहाँ से क्या डालते हैं
फैकल्टीज फैकल्टीज को
एक सेकंड
सर फैकल्टीज को इधर बिठा लेते हैं. यहाँ फैकल्टीज को मैं उधर बोल देती हूँ उधर नाच कर देती हूँ. बस ऐसा
एक सेकंड जैसे
हाँ तो मैं बोल रही हूँ कि कैसे स्टार्टिंग
प्रोफाइल में जाने के लिए बोल रहा हूँ
वॉच देन अदरवाइज दे कीप ऑन सिटिंग.
पेज पेज वाली वो कर रखा मैंने मैं लॉगिन पेज से. हाँ हाँ प्रोफाइल में बताऊँ. हेलो हाँ जी खोल लिया मैं.
ये चार लोग अपने आप करेंगे
मैम एक तो आईडी है हमारी आरएनएम सेंटर की प्रोफाइल और एक पेज है. जैसे मैं पेज से स्विच कर रहा हूँ ना तो अब नहीं आ रहा ना. कैसे रे प्रोफाइल से तो हो ही रहा है. हाँ पेज से नहीं हो सकता क्या. नहीं बंद किया वो तो भी टेस्ट किया था मैंने.
A very good morning to everyone. It's a beautiful Sunday morning, and I welcome you all on behalf of Rohtak Nuclear Medicine Imaging Therapy and Research Center, Association of Surgeons of Haryana, and IMA Rohtak, under the aegis of Society of Nuclear Medicine India, Hagen Chapter, and Indian College of Nuclear Medicine, for CME on current concepts of nuclear medicine, diagnostics, and therapeutics. Now let's begin our day with a quiz. So let's refresh our mind with Scintillate the Mind. To conduct the quiz, I would like to call the quiz masters on the dice, please. Dr. Sugandha Dureja, Consultant Department of Nuclear Medicine, Action Cancer Hospital, New Delhi. Dr. Kalpa Das, Assistant Professor, MCI Jhajjar. Dr. Shashank Chaudhary, Consultant ENT and Head and Neck Surgery, Kainos Hospital, Rohtak. And Dr. Kanish Markham, Senior Resident Department of Nuclear Medicine, SGPG IMS, Lucknow. Over to you, ma'am.
Good morning, all participants. So let us start with the quiz as early as possible now. So we'll have some rules and regulations. So we'll have two rounds in this quiz. The first round will be a screening round.
हाँ मिल गया.
In this round, each question will have 10 marks for the correct answer. Plus we have some negative marking, 5 marks for every wrong answer. And among you all, the top 6 teams will be selected for the next round. So So in the next round, we'll have rapid fire round in which we'll have around 4 questions for each team, and each team will be given 90 seconds to answer those questions. And I will request you to write your team numbers and a name from your team member in each paper what you submit. And please do not overwrite much, don't cut much, and write a legible answer so that we can give you points for that question. Okay. So without any delay, we'll start now.
सर कुछ लोगों के पास अभी शीट दे देते हैं अभी कुछ बच्चों के
Sheet.
अरे मैम रुक जाओ
Sheets and pen.
आप देख लो किसके पास नहीं आपने raise your hands who don't have a sheet
Pens.
So I'll read out the questions and it will also get displayed on the screen here. And your options will be on the screen. Shall we start now?
ready
The sheets.
अरे यस तो बोल दो भाई
Yes, sir.
अरे जी वो शांत
So, all the best to all. Question number 1. The risk of malignancy in thyroid incidentuloma or with focal FDG uptake on a 18 FDG PET scan is
10 seconds more
stunning of thyroid gland after pre-treatment whole body scan may occur at what dose of iodine 131?
10 seconds more
Which of the following are not a candidate for radioiodine therapy?
Ten seconds.
The recommended dose of iodine 131 for revenant ablation in a well-differentiated thyroid carcinoma is
5 seconds.
the recommended serum TSH levels for adequate radioiodine uptake is
5 seconds.
absolute contraindication for 18F FDG PET scan is which of the following?
Five seconds.
The half-life of 18-fluoro FDG is
5 seconds.
for false positive PET scan after treatment of a T2N1M0 squamous cell carcinoma of tonsil may include all of the following except mucositis, paralyzed vocal folds, osteoradionecrosis, or pharyngeal muscular activity.
5 seconds.
The half-life of iodine 131 is approximately
5 seconds more.
physiological FDG uptake may be seen in which of the following?
Five seconds.
Tracers used for thyroid imaging are FDG PET CT is used in which of the following?
Five seconds.
Inferior parathyroid glands arise from which of the following?
5 seconds.
Which of the following is not a contraindication for a thyroid scan?
Five seconds.
Low FDG uptake may be seen in which of the following?
Five seconds.
What does P stands for a PET scan in PET scan?
Five seconds.
SUV max in PET scan stands for what? Which statement is true regarding carcinoma prostate? Sorry. So option A is a biochemical recurrence is defined as increased PSA to more than 0.2 nanogram and measured at 6 to 13 weeks following prostatectomy. And option B is biochemical persistence is defined as persistence of prostate cancer due to continuous elevated PSA despite surgical treatment. Option C, PSMA PET CT is superior to conventional imaging for evaluation of suspected biochemical recurrence or biochemical persistence, and option D is all of the above.
10 seconds.
A patient presents with feature of thyrotoxicosis along with history of fever and neck pain. Identify the imaging diagnosis on thyroid scan.
20 seconds.
All of the following are true for lowest score except. So option A, no uptake or no residual uptake when used in PrEP. Slight uptake but equal to or below blood pool mediastinal. Option C is uptake above mediastinal but below or equal to uptake in the liver. Option D is markedly increased uptake greater than liver, and option E is any new lesion on response evaluation.
Five seconds.
That completes our round one. So one of us will come and collect your answer sheets now.
ओहो हो गया जी चलो चलो
वापस लाने के लिए भी थैंक यू also लेकिन 20 टीम का सर वो रात 11 बजे मैसेज हुए सुबह 7 बजे मैसेज हुआ है कि पहुंच जाएगा सर टेक्निकली जी Meanwhile, one more team. So we'll have a the end of our CME, after all the sessions, these questions which we have displayed will be giving answers and will be giving explanations. So, residents, we request you for the better learning, you please do attend that session.
We have the results for the first round now. Everybody's done really well. We'll be now announcing the final 16, so we'll go to the next rapid fire round. Team 15. Dr. Shivam, Dr. Lance, Dr. Saurabh, Dr. Manoj, and Vishnu.
One member from team, come here.
Please come.
One member from the team. Anyone come?
I think just sit here.
Team 3.
Just 3-6 seats.
Dr. Ravinder, Dr. Nishant, and Dr. Rahul. Team 1. Afghanistan, Dr. Nishant. Team number 4. Dr. Niti Yadav, Dr. Preeti, and Dr. Pooja. Team number 6. Dr. Sunaina,
Each by we request
and
the 6 teams
Prakash.
which have been shortlisted, please come forward.
Okay, so we have to have been divided for equally. Equally, and we're going to select the team who has done lesser of negative answers. So, but based on that criteria, we take team number 7.
7.
Dr. Isha, Dr. Mudit, and Dr. Mitra.
So we request 6 teams who have been shortlisted for the second round, please come forward, and the rest of team please keep behind.
नहीं मूव क्यों करवा रहे हो? मान लो वही तो यहाँ वही नहीं आंसर करते मूव क्यों करवा रहे हो? भाई जो टीम है वो तो असाइन है ना हमें मालूम उन्हीं के रिजल्ट एनालाइज करेंगे नहीं मेरे ख्याल में मिस हो जाएगा आगे के अब वही नहीं तो मतलब वो आंसर उसको कलेक्ट करके कर लेंगे
Please keep your markers on the top and left hand side. Keep your markers on the top here. Good.
दो पर्पस है ना एक एजुकेशन है एक अवार्ड है तो एजुकेशन तो सबसे होती है अवार्ड ठीक है
So, we'll just review again. This is the rapid fire round for all the 16. We'll be asking, we'll be giving you 90 seconds each. And within 90 seconds, as many questions as you can attempt. We have 4 questions for you. But if you're going slow, if you're taking more time to answer, you will not be able to attempt all the 4. Right? So that your time will finish at 90 seconds. And if you're able to finish all 4 in that time, that's good enough. And we'll start with each team, guys. So you'll have your 90 seconds separately. Right? Again, the same idea. Positive answer, 10 marks. Negative, wrong answer will be -5.
Everybody have their sheets with them? Everybody have their sheets? No? Raise your hands. Those are teams with the flags don't have the sheets.
Final 6 teams. Everybody have their sheets.
Just write your team number on top.
So every team will have different questions.
Yes.
Yeah.
Yes.
So it'll be, we'll start with team number 1.
Okay.
And then each team will have separate questions. So we'll start with team number 1.
Team number 1. Can you see? Yeah. So should we start? You ready?
Time starts now. Question number 1. Follicular carcinoma thyroid can be diagnosed on FNAC. True or false? Next. Question 2. Please see this image of the thyroid scan. What is the likely diagnosis in this patient? Hyperfunctioning thyroid nodule, multinodular goiter, Graves' disease, or thyroid neoplasm? Done? Next. Question 3. The radionuclide injected for a thyroid scan is used from the option. This is your last question. True or false? Again, approximately 5% of prostate cancers may not show uptake on a PSMA PET CT. You take your time. Done? Right. Team number 2.
Raise your hand. Team number 2, raise your hand.
You ready? Right. Start. SP inspect stands for SPECT. What is the full form of SP? Done? Next question. True or false again? Inflammation can cause false positive FDG uptake. Is it a true statement or false? Okay, see this scan and identify the radiological signs seen on the bone scan. Last question, second team. According to NCCN guidelines, PET CT may be helpful in which of the following? Done? You have time. Please submit your sheet, right? Team 3, please raise your hands. Right. Did we start? Okay. 10% rule is usually followed in which malignancy? Hereditary cancer, thyroid, PO, adrenal adenomas, or appendix tumors. Post-thyroidectomy, elevated TG levels and a negative iodine scan. What is it called?
You can also say pass. If you don't know the answer, say pass. We'll move on to the next. Pass.
Identify this symbol. Which organization does this symbol represent? It's a logo. Methods of administration for radionuclides include injectable, oral, inhalation, or all of the above. Still have time? You done?
I want to see your last question.
Do you want to go back to any question if you want? Second. Please submit your sheet. Fourth team. Are you ready? Starting. So, which of the following has a better resolution? PET, SPECT, or gamma camera? Next. True or false statement again? Carcinoma thyroid patients can be administered 100 millicuries of iodine therapy on OPD basis. Is it a true or false? Next. True or false again? Half-life of technetium 99M is 8 hours. So this is a 35-year-old female. This is a PET scan axial image. We're showing an arrow with update there. Do you think which of the following does this represent? Are you able to see the image? You want to go back to any of the questions? Done? Right. Next team number 5. Ready? Okay. Your first question. Disadvantages to the use
use of FDG PET in radiotherapy planning for head and neck cancers is all except next. True and false statement. FDG PET is superior to CT for detection of disease recurrence in ovarian cancer.
Next.
Identify the scan. This is a mirror image of a PET CT. What is this? Which PET is this? Try to see the similar to the file in make up for that.
Next.
True and false statement again. Pheochromocytomas arise from the adrenal cortex.
The third question.
Yeah. Last 5 seconds now. Your time is up. Team number 6. Ready? Should we start? True and false statement. MRI uses ionizing radiation. True or false? True and false again. Fluorothiazide should be administered for MITG scan or MITG therapy. So this is a parathyroid scan. You just need to tell us if it is a positive for an adenoma or negative. See the subtraction image here.
Next.
Relative contraindications for use of lenvatinib. Definition, when will you not administer lenvatinib? Thank you.
This includes the question.
And we're going to evaluate the final 6 teams and we'll announce the winners towards the end of the program. Thank you so much for your participation.
A big round of applause for all the teams that have participated. Please enjoy the snacks and sit at the end. We'll announce the winners at the end of the process.
I think we all should congratulate the organizer of the stage and these all 4 persons who run this time I think very well. And it was excellent show here. Let us see the result. Meanwhile, we are just organizing. We'll have a short inauguration and followed by our center. Okay.
Now, after the quiz, let's take the program further. We'll start with the inauguration ceremony, for which I would like to call on stage Dr. Rnm Center, President, Society of Nuclear Medicine of India, Northern Sector, Dr. Nishikant Namle, Secretary, Society of Nuclear Medicine of India, Northern Chapter, Dr. Manoj Raval, IMA Secretary, Rohtak Branch, Dr. Praveen Kundu and Dr. Rohit Kumar. और जैसा कि मां सरस्वती की आशीर्वाद के बिना कुछ काम नहीं करते तो उनका आशीर्वाद लेते हुए हम आज का ये कार्यक्रम शुरू करते हैं। Please light the candle of knowledge, which is a part of our rich Indian culture.
So, good morning, everyone. Now we would like to invite Dr. Kadwasa sir to light the lamp.
You also come.
And now I would like to call Dr. R.T. Kadwasa, Senior Professor Surgery, DGIMS Rohtak, for opening remarks.
Dignitaries on the dais, dignitaries of the dais, my dear colleagues, students, my colleagues. First of all, I must welcome the faculty who has come here all the way from far away to take participate in this short CME, and it is very one of the unique CME. Why we organize this CME or why we thought this thing? Dr. Praveen has been the academic mind, though she is in business of running a center, nuclear medicine, but she is from Allied Institute and has a academic mind. So, and we think that this is the topic or the subject where there is a communication gap between the surgeon, nuclear medicine physician, general physician, and the radiotherapist. All are not talking the same wavelength. And majority of what I will be run by department surgery, that as a surgeon, majority of the surgeons are not aware about this thing. So appropriate utilization of this thing will not be there. Apart from this, today, because we are not trained and we are not aware of these things, so our residents are also suffering because this lack of knowledge. And for that, it is important. And now the PET CT is so much so used, so that unless until we have a judicious use, then it will be unnecessary. So with this thing in mind, we today organize this thing, and with this, I thank all of you to come here and take part in it. Thank you very much.
Thank you so much, sir, for your inspiring words. And now, please stand up for our national anthem.
from Saraswati Mata. Now we will start our first session. The first session is, which we are trying to do, is the basics of PET-CT. Here we have called experts who are masters in their field and they have experience of more than 20 years per person. So the first session is decoding PET-CT basics with experts, and for this we will call on stage our eminent chairpersons. Dr. Nalin Sinha, ma'am is head of RMS Nuclear Medicine Department. Dr. R.K. Chaudhary sir, who is our own the most senior faculty, most senior surgeon faculty here in Rohtak. Dr. Sanjay Mara sir, who is professor and unit head in Department of Surgery, PGIMS Rohtak. Dr. Savita Singhal ma'am, she is senior professor and unit head in Department of Obs and Gynae. We would request Dr. R.K. Kanwasa sir to also chair this session. The first speaker for this session is Dr. Nishikant Namle sir. He is faculty in AIMS and our own beloved senior. So I would request sir to start with the session.
I would like to call Dr. Ashok Chauhan, Senior Professor Radiation Oncology, PGIMS Rohtak, on stage.
All right, I'll take over from here. Am I audible till the last? All right. So, good morning to all of you, and a warm welcome to the first CME organized by the Society of Nuclear Medicine India Northern Chapter, and capably hosted here by Dr. Parveen and her team. And greetings to all faculty and all students who have come here. And let's start off the morning with a very pertinent but a very basic lecture, PET-CT, a one-stop shop answer to the clinical queries. So basically, for the unversed, what is PET-CT? It's a hybrid imaging technique consisting of emission tomography, that is PET, and transmission tomography, that is CT. So we know that in a computed tomography, the CT, a beam of X-rays is going to traverse the body of the patient. That is called as transmission scanning. The images are acquired based on transmission scanning. Whereas in PET, we inject radioisotopes and we actually get radioactive counts from the patient. So we get emitted counts from the patient. That's why this is called as emission tomography, right? So a fusion of these two techniques is called as PET-CT or a positron emission tomography, computed tomography. Now it provides functional as well as metabolic information along with anatomic localization and characterization. Now most of you must have heard about the gamma camera. It's a machine that has been used for decades now, and the PET-CT is relatively recent. Although the PET technology was old, the PET-CT was used as late as 2001 by the University of Pittsburgh. That was David Townsend who actually invented it. So it's a relatively recent technology, but it comes with two distinct advantages. It has superior spatial resolution and superior image contrast. The third advantage is that there is a host of tracers that can be used with PET. Unlike the gamma camera, the development in PET radiopharmacy has been happening very rapidly. So even as we speak, there must be one tracer coming up somewhere in some lab in the world. So the commonly used radioisotopes, as you all know, with the gamma camera, all of you have heard of technetium 99M. It was part of the quiz also. Iodine 131, which has been used since 1927 for the therapy of thyrotoxicosis and thyroid cancer. Then the thallium scans that we all know of. Thallium, although it's not popular anymore, it's one of the isotopes that all of you must be aware of. In the PET-based isotopes, the most commonly used one is the fluorine 18 or F18. Now here that 18 is the mass number of that isotope, and basically we have other isotopes like carbon, nitrogen, oxygen also, which can be produced by any facility which is producing F18. But these have a very short half-life, so they are not very commonly used in our country. The other workhorse these days of nuclear medicine departments is what we call as gallium-68. Now this is different from the gallium-67 that you can see on the left-hand side in the gamma camera. Do we have a pointer? So this is different from the gallium-67, which was used initially for infection and inflammation imaging. This is gallium-68, and it is tagged to a variety of ligands to give a lot of tracers used especially for neuroendocrine tumor imaging and PET imaging. So we have FDG to start with, which is the workhorse of nuclear medicine, and all of us have heard of FDG PET scans. So what is this FDG basically? So FDG is a pseudoglucose, right? Being a pseudoglucose, what happens is it is taken up by cells which have high glycolytic rate. So if there is a tumor cell, okay, it's going to have a lot of anaerobic glycolysis going on, the Warburg effect basically, and it's going to show a lot of glucose uptake. Now, this FDG is going to enter the cell just like normal glucose enters the cell. But after it enters there, what happens is it will not be glycolized beyond the first step. So glucose FDG will enter the cell, it will become FDG6 phosphate, and it will get trapped in the cell. When it gets trapped in the cell, it will start emitting the positrons, which will subsequently annihilate and produce photons of 500 keV. So this is the basic principle of how FDG is taken up. This is just a brief diagram showing the same thing. How it gets blocked at the stage of FDG6 phosphate in the tumor cell. Now this is a PET-CT machine I have shown you. Obviously now you have a couple of scanners in your city. But for the unversed, this is how a PET-CT scanner looks. And then we have a technology called as coincidence detection. Now this coincidence detection is basically a mechanism in physics by which we get the PET images. You need not go into the details of these. And this is how normal FDG PET scan looks, right? So we see a lot of uptake in the brain images, physiological gray matter uptake. We see uptake in the liver, mild uptake in the spleen, mild uptake in the bone marrow, excretion through the kidneys, and activity visualized in the bladder. So the pertinent questions that are posed today to the PET-CT physician are where can PET-CT help me? And this is a list of indications where PET-CT can help us. So one, in the diagnosis of primary tumor, we can detect tumors early. We can sometimes differentiate between malignancy and benign lesions. We can also detect multicentricity of lesions. Vis-a-vis the question of staging, yes, it's good for locoregional lymph node status evaluation in some malignancies, not all. And in distant metastasis evaluation, this is the prime role of PET-CT. The next role is monitoring response to treatment. So if I have given a therapy to a patient, let's say I have given chemotherapy, or let's say even I have given some immunotherapy, and I want to assess whether it has worked. PET-CT is one of the very good modalities to assess this. The last is detection of disease recurrence and metastatic disease. Sometimes we have a question in our minds whether what we are seeing is a viable tumor or scarred tissue, because post-surgical inflammation, post-RT inflammation also at times can create false positive results. But nevertheless, in large majority of cases, FDG PET will be able to provide us the answer. So let's see some examples. Now we have this image which shows a mass lesion in the pancreas, the distal body and tail of pancreas, and the upper panel actually shows an image which is not FDG avid, whereas if in the lower image you see there is another mass and it is highly FDG avid, and then you are seeing some omental nodules as well. So basically this mass was benign and this was malignant. Now based on this funda, previously there was a concept which was given when we were students that SUV max of more than 2.5 should be considered as malignant. Now as we grew from students to faculty and now additional professor, we have realized that the SUV is not really a criterion by which you can judge whether something is benign or malignant. But in the negative sense, you can say so most of the times that if there is no uptake, then it is more likely to be benign. Moving on. Now, this was a case, that presented to our department with weird cerebellar signs and symptoms, and the clinician was absolutely clueless as to what could be the possible cause. So, after exhausting the routine evaluation, they actually came to us and said that could this be paraneoplastic and let us do an FDG PET scan. And when we did an FDG PET scan, what did we see? Now, you can see, the cerebellum on both sides, along with the vermis, is showing very high uptake, even much higher than the cerebral cortex. And on the whole body imaging, what did we find? We found an ovarian teratoma with an FDG avid malignant. This was basically a case of paraneoplastic. This was something that no other modality could have possibly, come to. Again, another patient presenting with paraneoplastic cerebellar degeneration, symptoms of ataxia, loss of balance, recurrent falls, and the clinician was absolutely clueless. When we did the FDG PET scan, what did we find? We found the lung nodule, which was subsequently, found to be a malignant lung nodule. So this was a carcinoma lung, and it was very nicely demonstrated on FDG. And in this case, the whole body image actually again ended up showing a lung mass with irregular spiculated margins and a lot of FDG uptake. So in cases of unknown primary, to find the possible primary site, PET CT is a very good modality as a one-stop shop imaging technique. Now look at this particular patient. You can see the baseline image here. Lots of disease you can see, multiple sites in the skeleton that are involved. And you can see here, these are the representative fused images in the sagittal section, and you can see uptake here, which subsequently has completely disappeared. So this was a 70-year-old female which had a Hodgkin's lymphoma, and after 4 cycles of ABVD, you can see that the disease is gone. So in one modality, imaging the whole body beautifully, showing the extent of disease and demonstrating that the disease is also responded, which is in line with what the clinician is expecting. This is a beautiful modality. Now, this was a 5-year-old boy who, actually presented with fever for 4 weeks, and there were no localizing signs. By the time he came to the clinician, they found some kind of a neck swelling, and they referred the patient for a PET CT scan. And the biopsy actually turned out to be LCH after we guided them as to where the biopsy should be performed. Now, one could very well argue that had they done an ultrasound, had they done a CT, these nodes would also have been seen, but then we wouldn't have been able to, find the extent of the disease. So, PET CT is a good modality if you want to try and tackle the problem at one go. Now, this is a very rare case, tumor-induced osteomalacia. This is a scan that I have taken from literature. And tumor-induced osteomalacia, most of the times for years you will be having a patient who is having a lot of fractures, lot of osteomalacia, elevated FGF23 levels, and CT and MRI many a times not able to point in the right direction. And you can see here an FDG PET scan was done, and it actually ended up showing a lesion here just medial to the maxillary sinus. And this was the culprit lesion. This was subsequently excised, and the patient was cured. Now, this is a patient, who had pancytopenia and hepatosplenomegaly, and clinical picture of hemophagocytic lymphohistiocytosis. And again, the clinician wants to know whether this is idiopathic or this is secondary to some malignancy. Because we know that HLH is many times secondary to malignancies. You can see hepatomegaly, you can see splenomegaly, you can see a lot of bone marrow uptake, and you can see some lymph nodes also. So we guided them towards the site for biopsy, and the biopsy returned as lymphoma. So this was HLH secondary to a lymphoma. Sometimes it helps in resolving other dilemmas also. This was a patient who had come with bilateral adrenal masses. Biochemically, he was non-functional, and the clinician was thinking that this could be metastasis from somewhere. And then a PET CT was done. Again, this image has been taken from literature, and this patient actually ended up showing bilateral adrenal histoplasmosis and was an immunocompromised patient. So PET CT was useful in ruling out any other cause for those adrenal lesions. Here you see the typical pattern as is seen in infective pathologies in the adrenals, smooth outline and diffuse uptake. Now, how about baseline staging? Yes, now we have a patient with an RCC here. You can see here highly aggressive tumor with lot of glucose uptake, FDG uptake. But when we did a FDG PET CT for staging, what we found? We found metastasis to bilateral lungs as well as the skeletal sites, as you can see here in this image. You can see the lung nodule, you can see the skeletal metastasis also at this location. So similarly, another patient who came for baseline staging, and look what we found, multiple sites of skeletal metastasis. So many times this will entirely change the management. Now this was a patient with an adrenocortical carcinoma, which was again non-functioning, but you know that these are very aggressive tumors, and for prognostication and detection of metastatic sites, we have done this FTG PET, and it showed multiple cannonball lung metastasis. Subsequently, the patient died in 1 year. Now, in the recurrent disease, also yes, PET has a role, especially if the biochemical markers or tumor markers are pointing towards a disease recurrence, or if the clinician is suspecting that there could be a new site of disease recurrence. So, this is again one question that was asked in your quiz, the tennis syndrome. Now, this is thyroglobulin elevation with a negative iodine scan. So, see in thyroid patients, once they, stop showing any uptake on the radioiodine scan, but have persistent high thyroglobulin levels, we call it as tennis syndrome. Now, the sensitivity of PET scan in this disease is reported to be about 70 to 90%. And this is an image from our own department where actually this patient had a tennis syndrome, and actually you can see this foci in the bone, and you can see electric lesion here in the bone. So this patient had bone metastasis. So that was the source for his elevated thyroglobulin. Same patient, same images, just transaction results. And then sometimes patients do get unstaged. Yeah.
2 minutes, I think.
Yes. So then we have this, carcinoma right breast, which was referred to as post-surgery and post-chemotherapy. And when we did a PET scan, you can see it started with disease all over the body. So this was upstaged on the PET CT. And again, detection of recurrent disease. Now, if you see, sometimes very fine findings will be seen. You can see a retroperitoneal nodule here, and this was recurrent disease from an RCC. And again, some such imaging you can do to detect disease recurrence in various malignancies, not only RCC. There's a wide spectrum actually. And assessment of response to therapy, you can see here, this patient initially had a lung nodule, and then subsequently after therapy it has disappeared. So response assessment to therapy. I'll just move briefly to Dotanoc. This is normal Dotanoc scan, and I think Dotanoc is being done here at Dr. Parveen's facility also. So Dotanoc, has a special affinity for these somatostatin receptors, and wide variety of indications including FEO, para, NETs, MTC, TIO, ectopic Cushing's, and assessment of PRRT response also. It confirms the neuroendocrine nature of the lesion. So this was a patient where there were multiple liver lesions. Do a Dotanoc, demonstrate uptake, it's neuroendocrine. You can also see the primary in the pancreas. This is a FEO, big lesion that the endocrinologist wanted to characterize. So this shows uptake on the Dotanoc as a FEO. And here we can see, parathyroid adenomas as well as FEOs in the same patient, in the same setting. And here you can see, incidentally detected, this was a paraganglioma with nodal recurrence, and we found glomus tympanicum tumors on both sides. Incidentally, this is a patient with multiple paragangiomas. So no modality is going to show you these images in one go. And then this was a bladder paraganglioma. You can see the MIBG scan, no significant uptake seen, but to see the Dotanoc scan, excellent uptake. So this helped us in planning therapy. So we gave PRRT instead of MIBG therapy. And after giving PRRT, how do you assess response? So this is a pre-therapy scan, and this is a post-therapy scan. So we'll talk about PRRT later, but you can see the significant response. So for response assessment also it can be used. The PET scans that are used are fluorocholine, F-dopa, gallium, exendin, and PSMA. Right? So this is a patient, who is having one lesion on the EP scan, second is suspicion, and we don't see any third lesion. But when we do a choline scan, look at what we find. 1, 2, 3. Clearly demonstrated 3 parathyroid adenomas. So this is, uptake in corresponding sites on both scans. So F-dopa and Dotanoc are also the PET modalities for insulinoma imaging. But the best one that has come right now is what we call as exendin. Now exendin is GLP-1 analog, and this is showing clear uptake in the head of pancreas, and this was an insulinoma. So as per the malignancy, now we are developing newer and newer tracers, and they are providing with an answer. And this is multiple insulinomas in the same patient. Okay, so you can at times have more than one entity, and other modalities cannot correctly characterize it, and you will end up removing only one lesion. Patient will still have symptoms. So take home message from my lecture for all of you is PET CT is sometimes a one-stop shop imaging, and sometimes it is a last resort. It addresses clinical queries in a variety of oncologic and non-oncologic indications too. I focused on the oncologic part here. And newer PET tracers are imaging and heavily contributing to precision medicine. I hope all of you enjoyed this lecture. Thank you.
Thank you, Dr. Kamli. I think we can take 1 or 2 questions.
See, one you have said that can be used to assess the lymph nodes.
Yes.
Is it possible now with the PET CT, we can dispose of the sentinel node biopsy? If we can exactly assess the lymph node enlargement in breast CA and the lymph node, then we can dispose of with the sentinel node biopsy. There is no need. It is possible.
I don't think we have reached that stage right now.
We have not. Yes, I think probably we have not, but probably there is maybe.
Yes.
We have right now recently given this topic that whether it is how much what distance research. I don't know. Much study has been done, but because the majority of the places sentinel node facility for sentinel node biopsy are not available. Because even nuclear medicine facilities are not available. So even if this is also the nuclear medicine modality, and if this is possible, then probably that may be. Thank you.
Any questions from the audience?
Any students want to ask me?
Dr. Nishikant. Thanks for the excellent talk. Ultimately, the outcome of the malignant disease depends on its anatomical extent. That is a hard and true fact. And nowadays, the nuclear medicine is playing the crucial role in the early pickup of this disease. What is the status for the? Can it be used for screening purposes in the near future? Just like we have mammography for early detection. What is the current status?
So the current status and probably the status in over the next decade is that it won't be used as a screening modality. The reason being that you see there is a lot of radiation exposure which is involved in this technique. So earlier on the scanners where we used to do a whole body PET scan. In fact, the exposure from the whole body CT is more than the exposure from the PET, but nevertheless you have a dual exposure. So where you want to use something as a screening modality, you would rather not use something that has such high amount of radiation exposure. So plus the indications that we are catering to right now, as I mentioned, detection of primary tumors where there is wide clinical suspicion, strong clinical suspicion, or for assessing the response to therapy, or for finding out the primary, in these cases of cups or VO. These are the robust indications which have been established till date. And my personal opinion is that it should not be used as a screening modality.
So when we're looking for screening, we'll always look at something cheap, easily available with no collateral damage. So this is actually not a very cheap modality. And there are cheaper ways of screening, which would not give you that kind of radiation exposure. So as of now, there's no role in screening.
I want to agree that scientifically there is no role of PET CT in screening, but nowadays that so much things are available on internet. Now people self-refer them for PET scan. So the affluent society who are having cancers in their families, they are self-referring for PET scan. We get a lot of cases self-referred.
So at least at my institute, that's All India Institute, I have the luxury of refusing such cases.
But I don't have that luxury, sir.
You cannot afford that luxury.
No, so a lot of centers we ask for a physician referral. We don't go ahead, on the word of the patient only or the relative.
So Rishika very well explained your personal experience.
Thank you.
So you use one term Dota knock and Dota pro.
Dota knock, Dota talk, and Dota
Yeah,
test.
so many residents are sitting here. I myself don't know what it is. Can you please highlight on
Yes.
this for the various types of these?
So I will go into the practical part rather than the actual difference in the chemical structure, because although I can explain that is slightly redundant for the audience, I'll explain the conceptual difference. So basically here you should understand that this DOTA basically is a bifunctional chelating agent. Now we have always seen mommy or daddy holding two kids, one on the right hand, one on the left hand, and crossing the road. So this DOTA does exactly like what a parent does. It holds octreotide on one hand and it holds the gallium-68 on the other hand, and it takes both of them together. So this OC is octreotide. Now we have somatostatin or SSTR receptors in the neuroendocrine tumors. Now we know that octreotide is an 8 amino acid version of somatostatin, right? Because somatostatin has a blood half-life of less than 3 minutes, so we can't use somatostatin. So octreotide is the version that allows us sufficient biological half-life to tag it to something and to image. Now, when this DOTA is tagged to uploaded, we get DOTA top, the chemical structure changes slightly, we get DOTA not, it changes further slightly, we get DOTA T. What happens because of this is the specificity towards the particular receptor changes. So, for example, you see this last DOTA T, it targets majorly somatostatin receptor subtype 2. There are 5 main subtypes of somatostatin receptors. The DOTA top, on the other hand, targets somatostatin receptor 2 and 5. Whereas the DOTA knock, it targets somatostatin receptor 2, 3, and 5. So if you ask me if I want something as an imaging modality, then I want to be as sensitive as possible and target as many receptors as possible. So for imaging, it's preferable that we use DOTA knock. And for therapy or the PRRT that we give for neuroendocrine tumors, I want to be as specific as possible. And the most widely and extensively expressed receptor on those tumors is type 2. So in therapy, we prefer to give lutetium dotatate. So that is the difference. Now this DOTA you can tag with gallium-68 and use for a PET scan. You can tag with lutetium-177 and you can use for therapy. So if you have a doubt of a neuroendocrine tumor in your mind, then you should write for a DOTA knox.
That's why I'm asking as a clinician, but we should
You should write advice DOTA knock PET. Instead of just an FDG PET CT would get done unless until somebody really looks at the form and says no this requires.
But from ASIP costing is also different for different type of.
Costing is different. Maybe Nalin ma'am can answer that question because
regarding the cost. So this is different from the government hospitals. In a private center, the cost depending on the center for a normal PET scan would be between 20 to 25,000. Of course, some centers it is between 10 to 20,000 also. A DOTA knox scan is again in a similar range.
Government hospitals we generally do it for 7,500 rupees for the patients who can pay, and exempted for those who can't.
Clinician also have to go on a long way to learn these things, so that we can advise on.
Yes. So thank you all for your.
One small question. Residents like if they are referring the patient for PET CT, any preparation required before going for scan?
Yes. So generally we try to keep the blood glucose levels below 160. So for that, the patient needs to be fasting. If not that, 4 hours of fasting is sufficient. Generally we ask for 6 hours. So what we instruct is सुबह उठ के 6 बजे आप चाय और 2 बिस्किट ले सकते हैं, उसके बाद कुछ नहीं खाइए. Generally every PET scan in my department starts around 11:30. So by that time, most of the patients would tend to have a glucose level of less than 160. So that's point number 1. Point number 2 should have a recent RFT in case contrast is required. We don't routinely use contrast because FDG itself acts as a metabolic contrast. So in large majority of the pathologies, unless and until the question is deciding whether a tumor is resectable or no, or this key question to be answered with the help of contrast, till then we don't use it. But as a backup, we always ask the patient to do blood urea and creatinine. That's the second point. Third point is if the patient is diabetic, they should tell us because we don't keep such patients fasting for a longer time, and we also don't ask them to take their anti-diabetic drugs before the scan. Okay, and the second last point is if the patient is on steroid therapy, then that can actually alter the biodistribution of the FDG, and it can lead to a lot of glucose uptake or FDG uptake in insulin-dependent sites rather than the tumoral sites. So there's a possibility that we will underestimate the disease burden, underestimate the SUVs, or sometimes miss the pathologies which are highly FDG away. So if a patient is on steroid therapy, we ask the clinician, can you stop it for 24 hours? Can you stop it for 48 hours? If yes, please do. If you can't, then we'll have to report it out as scan done with ongoing steroid therapy and altered biodistributions. So these are the basic things that the residents should be aware of.
Can you just explain the total time, the whole process for everybody? Once a patient comes to you?
Yeah, so once a patient comes to us, well, it differs cross-clinically. I mean, I'll tell you the standard procedure because in a logistically challenged department like mine, we end up doing 55 PET scans in a day. So the logistics are slightly different, but I'll tell you what the standard procedure is. So the standard procedure is that the patient is fasting. He's called, to a place where our residents can take history before the patient is injected. Because after the patient is injected, then you are going to have radioactivity coming out of the patient. You really don't want to sit beside him and take history. So you ask the detailed history to the patient, send him to the injection room. So there FDG is injected. Standard dose that is injected is 10 millicuries. If you calculate it per kg body weight, according to guidelines, it should be 150 to 220 microcuries per kg body weight. And after this isotope is injected, the patient is asked to sit quietly in a separate room, which is called as the post-injection waiting room. And 45 to 60 minutes is the uptake period in which the FDG that we have injected actually goes and distributes to the tumor sites or the infectious sites in the body. And in this period of time, the patient is not supposed to move around, because if he moves around, there will be a lot of skeletal muscle uptake. He is not supposed to be talking, because you will see a lot of artifactual vocal cord uptake. So after 45 to 60 minutes, we take him up for the scan, and the scan could take a variable period of time. Generally, 10 to 12 minutes is what we require. In this, the CT takes only 1 minute. The PET part takes a longer time. And just before coming for the scan, it's better that the patient avoids and then comes for the scan. During the scan, it's better that the patient not move, because otherwise there could be a misregistration between the PET and the CT parts. Most of the times it's correctable, but sometimes we have had instances of patients getting up from the scanner, going to the bathroom and coming back and lying down. So you really need to explain the process very properly to the patients. And it's a difficult process, but usually we have cases who are doing recurrent PET scans, lymphomas, they undergo 2, 3, 4 PET scans, oncologic patients. So once they do a PET scan, they'll remember it, how it is to be the next time, and that makes your job quite easy. So I think that's it.
How do you prevent the family getting the radiation when it comes back home?
So here you need to understand the concept of what we call as the gamma ray constant. Okay, so basically what is going to happen is, once we have injected the isotope to the patient, what is going to come out are 511 kV photons. Okay, but at the same time you have to remember that the half-life of that isotope which we are injecting is only 2 hours, 109.8 minutes to be precise. Plus there is a component of biological elimination, because the kidneys will be excreted. So the effective half-life is reduced to almost something like 1 hour. Right? Now, who should be worried about radiation coming out from such a person? You should be worried only about pregnant ladies and very young children. Otherwise, by and large, for the amount of time that is normally spent by a caregiver with the injected patient after he comes out of the scanning room, so it's like almost 2 hours by the time he comes out. So the activity is already very less. Going by current national ARV limits, a caregiver of a patient can have an annual exposure of 5 millisieverts, and the general public should not get more than 1 millisievert. So if you ask me frankly what I would tell my patient, I would tell him, if you have a separate car, just go home in a separate car, don't use public transport. After going home, for a period of about 4 to 6 hours, stay in another room, or at least 6 feet away. So because radiation exposure reduces according to the inverse square law. So if you just step back 1 meter from the patient, the exposure that you are going to get is going to be 1/4 of what it will be at 1 meter close. So these basic principles of time, minimum time to be spent, maximum distance from the patient for as long as possible, and shielding if possible. So these are the instructions that we tell a patient. But generally speaking, with PET, there's not much of an issue reported either in scientific literature or in personal practice.
Thank you, Dr.
Just in the lighter way, and कार के पीछे लिखा था दूरी बना के रखें, तो ब्रेक तो ऐसा ही पेशेंट के पीछे लगाया जा सकता है, दूरी बना के रखें.
So yeah, we'll invite the next speaker now.
Yeah, the next speaker, Dr. Snmi Ahmed. He's an additional professor, nuclear medicine at AIIMS, and he will talk about PET-CT in breast and gynecological malignancies.
Thank you, Dr. Good morning to everybody. I'm going to speak about breast and gynecological malignancies. जब हम एक्चुअली 11th और 12th में गए थे तो उस टाइम जो हमने सबसे इंटरेस्टिंग टॉपिक लगता था वो तो रिप्रोडक्टिव सिस्टम ही लगता था. Frankly, people I don't know about you people, but that really I find it very interesting. So similarly, when Praveen told me that you're going to give lecture on this, so I to talk about the physiology and anatomy of this. This is interesting. I'm going to talk about the pathology. This may not be so interesting for you people, but I will try to make it interesting. So actually, I'm going to discuss the PET role in breast and gynecological malignancy. There is a simple funda for the PET CT. Dr. Damle has explained it very well. So PET CT is like we have many type of PET CT. We have FDG PET CT, we have gallium protein PET CT, we have DOPA PET CT, we have PSMA PET CT, and we have different. It is like wearing a suit. शादी में जाना है तो अलग किस्म का पहन लो, आपको बाजार जाना है तो अलग पहन लो, घर में जाना है तो अलग पहन लो. डिपेंडिंग अपॉन आप कहाँ पे हो उसी हिसाब से आप पैट भी यूज कर सकते हो. सो पहले क्या होता था हमारे टाइम पे एक ही पैट होता था एफडीजी पैट सीटी. नाउ with development of other PET CT, PSMA PET CT है, अगर किसी को CA prostate हुआ है तो उसको गैलियम PSMA PET CT लिखना है, वो उसको FDG PET CT नहीं लिखना है. अगर किसी को CA लंग हुआ है तो उसको आपको FDG PET CT लिखना है. अगर किसी को न्यूरोएंडोक्राइन ट्यूमर हुआ है तो उसको आपको गैलियम PET CT लिखना है. तो डिपेंड करता है पेशेंट की इंडिकेशन क्या है, उसको डिजीज क्या है और उसको कौन सा पेट करना है. सो मतलब जनरल स्टूडेंट्स लोगों के लिए ये मैं एक्चुअली बता रहा हूँ. बट अभी कमिंग टू माय टॉपिक, जो ब्रेस्ट इमेजिंग पहले डिस्कस करूंगा मैं, एंड देन आई विल गो टू द गायनेकोलॉजिकल मेलिग्नेंसी. इन ब्रेस्ट इमेजिंग ऑल ऑफ यू नो, आई थिंक द मोस्ट ऑफ द पीपल हियर, those are sitting as an audience, both of they are in the oncological practice, I believe. Though the PET CT has many other role also. ऐसा नहीं है कि आप लोगों को यही कंसेप्ट होता है कि PET CT means oncology. It is not like that. PET CT is also used for non-oncological indications like infection and inflammation imaging. PET CT is also used for the neurological imaging, where we diagnose different type of diseases. PET CT is also used for cardiological indications and has plenty of other roles also. So, but here we are going to talk about the oncology because the audience, I believe, belong to the oncology background. So, coming to the breast cancer, in breast cancer we have different imaging modality. हम ये नहीं कहेंगे कि PET CT ही सब कुछ है. आपने PET CT आया तो आप सब कुछ रिप्लेस कर गया. मेमोग्राफी का अपना रोल है, अल्ट्रासाउंड has its own role, and MRI has its own role. तो PET CT का रोल कहाँ आता है? I'm going to tell you people that where the PET CT can come, where the PET CT can be used in breast cancer. Not for every patient, so we need to be specific and we need to be precise where we are having advantage and where we are having disadvantage. So coming to the breast cancer, so these are the imaging modalities which are commonly used. Coming to the mammography, no investigation can replace mammography. If the question is initial diagnosis, if we have a suspicion of breast cancer, whether this patient is having breast cancer or not, so the mammography will be the best. First of all, if there is any suspicion, best thing is to go for the mammography. And if patient having the lesion on the mammography, so then you can proceed accordingly. Then you may do ultrasonography if required to go for correlation, and then you can do the FNAC, and then depending upon the stage of the tumor, then the PET can be done. Like if the patient is having stage 1 disease, there is no need of PET CT. Why their PET CT should be done? Because the disease is very well in the breast, maybe in axilla, so there is no need of doing the best PET CT in this type of patients. Because we are not suspecting anything beyond that. When we are not suspecting anything beyond that, there is no need of doing the PET CT. So I will say for initial diagnosis, PET CT has no role in breast cancer. So for initial diagnosis, the mammography will remain the standard of imaging modality, and then the ultrasound may be done, and then FNAC. Depending upon the finding, clinical staging, then PET CT come into the picture. This is mammography classification. I will not go into that. I have 83 slides. I am sure that I will not be able to cover it in 15 minutes. So please let me know. मैडम कहाँ चले गई? अभी तो एग्जामिनेशन के टाइम खड़ा रखा था आपने तो. नहीं प्लीज आप बैठ जाइए. जस्ट मुझे बता देने का मुझे रोकना है. क्योंकि आई एम नॉट सुनाइंग दिस. सो यूएसजी मैंने आपको बता दिया है, वो सिर्फ मेमोग्राफी को कोरिलेशन करने के लिए काम आती है. जो मेमोग्राफी पे हमें वी हैव अ सस्पिशन whether this lesion is there or not. So in these type of situations the US ultrasonography is done. Again the MRI have specific indication when there is a dense breast, when we have doubt on mammography and like that. So I will not spend much time on these things. I will directly go to the role of the PET CT in breast cancer. I have already told you that
for initial diagnosis. PET CT is not done for initial diagnosis of breast cancer. I'm not talking about all other cancer. You cannot take this message and put that PET CT is not used for initial diagnosis of breast cancer. For breast cancer, for initial diagnosis, PET CT is not done, mammography is done, and then FNAC and all other investigations is done. Where the PET CT should be done? For the initial staging. When the patient is having dense breast, when there is inflammatory breast cancer, when there is breast implant, and selected early stage patients. Why? Because in inflammatory breast cancer, we suspect the patient may be having, because this tumor is aggressive type of tumor, we may suspect that this patient may be having the metastasis to other part of the body. So in these patients, we need to do the PET CT to assess the different distance metastasis. In dense breast, when we are going to go do the mammography, all the picture may be white. We may not be able to differentiate the lesions. So in these cases, PET CT may be useful. And patients those are having breast implant, again, mammography will not be helpful in these cases. Here we can do either MRI or PET CT for the diagnosis. And then it can be used for selected early stages. Where we have doubt on CT or metastatic bone scan, we have done, we are not sure whether this is metastatic or not. So in these cases, the PET CT may be used for initial staging. Coming to advanced stage disease, like we can say, patient those are having disease 3 and more, patient having invasive type of histopathology. So in these cases, the PET CT is quite useful because stage 3 and stage 4 disease of breast cancer, there are chances that this patient may having the metastasis and may not having the metastasis. So it is important to know whether this particular patient is having metastasis or not. So stage 3 and stage 4 disease, PET CT is indicated. So the next indication of PET CT is monitoring response to therapy. This is established. I think there is no need of going for if the patient is affording and if the patient can do this. I think for response evaluation, suppose we have given the neoadjuvant chemotherapy to the patient and we wanted to know whether the patient is responding to this particular chemotherapy or not. So the PET CT will be the most appropriate modality, as Dr. Damle has discussed for response evaluation of other detection detection of regress with the PET CT will be more appropriate rather than any other structural modality. Like in CT, we will see that may be a fibrotic nodule. We will not be able to tell that whether this particular nodule is a recurrent disease or this is a fibrosis. So in these cases, PET CT is going to help us in better. So I will not go too much into the theory. I will directly go to the images because theory is always boring. So I will give you this picture and I will explain where the PET CT is indicated in breast cancer. Like this patient is 35-year female, patient having CA breast. This patient I was telling for baseline staging, like this patient having the dense breast. This patient has 2 lesions in the breast. So one lesion is clear. This was detected on the mammography, and this patient is also having the axillary lymph node. So our question is solved here. We need not to do anything else. But doing PET CT, we have seen there is another lesion which can be detected on the PET CT, and it will be difficult to detect on mammography because on mammography most of the things will look like same. So here the PET CT is going to help us when we are looking for the multicentric disease, or where we are looking for the other type of other lesion in the rest of the breast. This is another patient having CA breast in upper outer quadrant, and the patient is having axillary lymph node. Since the lesion is not so big, this may be early disease. We are not suspecting any metastasis, but we can see there is a lesion in the sacrum. So PET CT help us in detecting unexpected metastasis. That is low, small metastasis, isolated metastasis. So these type of patient, patient we get benefited by the PET CT, but in this type of patients. This is another patient having CA breast in the left breast, as we can see, and this having the axillary lymph node, and as we can see from these small arrows, there are internal axillary lymph nodes. So no imaging modality is going to tell us about the internal memory lymph node status. So PET CT will give us a good idea about the metastasis in the internal memory lymph node, like as we can see here. They are very small lymph node. Hardly we can appreciate on the CT, but on the PET CT they are showing metabolic activity, and with the help of the PET CT we can detect this as a metastasis. So we have actually discussed initial staging work of with the PET CT. Then we have seen metastasis. Now PET CT has an established role in detecting the distant metastasis in breast cancer. Like in this case, I can show you this patient is having left breast lesion. In addition to this, this patient is also having lung nodule and then the bone metastasis. There are many other metastases, as we can see. These are black spot of metastatic. So from this type of patient, we need to do PET CT, upfront PET CT, because this will give us a better idea where the disease is there, and in follow-up we can give the chemotherapy, and then we will assess the response after doing the PET CT. So these are the literature and guideline. I think it will take a lot of time to cover this, and I will directly go to the next indication, that is assessing the response with the help of PET CT. As we can see in these images, this patient is having, she is 37-year female having right breast cancer, and this patient having the primary in the breast. As we can see, this is a small lesion, so the pictures are not so clear. And patient undergone 3 cycles of chemotherapy. After the chemotherapy, the PET CT was repeated. As we can see, there is increase in size of the primary. There are multiple other lesions which has appeared subsequently. That means this patient is not responding to chemotherapy. So with this type of patient, those are not responding to chemotherapy, then there is no fun of continuing same chemotherapy. So PET CT will tell us whether we need to continue the same regime or we need to change the therapy. So in this case, we can easily say that this patient is not responding to this particular type of chemotherapy. So it will be always better to change the chemotherapy or the treatment in this type of patient. So from the PET CT, we can tell whether this particular therapy should be continued or not. This is another patient having CA breast. This patient treated in 2015 and had bony recurrence in 2020. As we can see, the patient is having sternal lesion and then the vertebral lesion. Patient undergone the radiotherapy. This was the baseline scan, having the vertebral lesion and the sternal lesion. On the follow-up, as we can see, this lesion has resolved. This vertebral lesion is also resolved, and this patient has completely responded to the radiotherapy. So here the PET CT helped in assessing us the response to the radiotherapy. So here the PET again will tell us whether this patient is having any residual disease or not. On the CT basis, we may not be able to tell because there is a sclerosis. We are not sure whether this is a residual disease or this is just post radiotherapy sclerosis. This is next indication of PET CT in breast cancer, that is detection of recurrent disease. As we can see from these images, this patient is having CA right breast. Patient was operated in August 21. Then patient had small nodule in the chest, as we can see from here, the CT images, and we were not sure whether this is a fibrosis or there is a recurrent disease. Patient undergone PET CT. On the PET CT, as we can see, there is a local nodule, and this nodule is showing metabolic activity. That means there is a local recurrence of the disease. Here the PET CT not only given the local information, but in addition to that, we can see a small internal memory lymph node. If we will not do the PET CT in these type of cases, so we are definitely going to miss the internal memory lymph node, and we will only treat this patient, this particular lesion. So the treatment will not be complete in this patient without doing the PET CT. Another important indication of PET CT is patient those are having breast implant. Like in this case, this patient having CA breast treated, and the implant was given to the patient, and then after that there was a suspicion for the regress. As we can see, there is a small thickening over here, there is a small thickening over in this region, and there are small axillary nodes. So in these regions, if we are not in this type of patients, if PET CT is not done, like we cannot assess with the help of CT or mammography or any other imaging modalities until unless we are not in the PET CT.